ला दे जो मुझे पढ़नी। Antenatal assessment of fetal well-being. I'm Dr. Rekha Agrawal. So today we'll deal with the topic antenatal assessment of fetus. So majority of the fetal deaths occur in the antepartum period, that is in the utero. The important causes of death are first is the chronic fetal asphyxia hypoxia, that is the intrauterine growth retardation. Then another is the maternal complications like diabetes in pregnancy, PIH, infections in pregnancy. Then fetal congenital malformations, they may be because of the different reasons, and unexplained causes are also there for the fetal malformations. Now comes the rationality of antenatal fetal test. The test must provide information superior to that of the clinical evaluation. Then only this is more significant. Test results should be helpful in management to improve the perinatal outcome so that we can reduce the fetal death. Benefit of test must outweigh the potential risk and cost. The measures that can be taken when a fetus is found compromised. So what we should do? Bed rest, fetal surveillance, drug therapy, urgent delivery of the fetus, term or preterm, neonatal intensive care, termination of pregnancy for fetal congenital anomaly. Clinical evaluation of fetal well-being at antenatal clinic. First visit. Fetal well-being depends on satisfactory maternal health throughout the pregnancy. After a thorough clinical examination of the mother, the investigators are initiated as early as possible. Investigations are started as early as possible. CBC, blood grouping, blood glucose, HIV, HbSAg, VTRL, serum thyroid stimulating hormone, then genetic screening, which is done in the first and second trimester, maternal serum alpha fetoprotein, triple test at 15 to 18 weeks for the mother to detect NTD or Down syndrome, and sonography. Now comes the clinical evaluation of fetal well-being at antenatal clinic. So what we should do, we should explain the subsequent visits to the mother. At every antenatal visit, the following clinical parameters are taken into account for assessment of the satisfactory progress of the gestation and the fetal well-being. So what is these? They are the maternal weight gain, blood pressure monitoring, assessment of the size of the uterus and the height of the fundus. At term, the SFH, that is the symphyzofundal height, is very useful for screening for the further investigations, whether there is IUGR baby or not. Clinical assessment of excess liquor or scanty liquor to detect the placental insufficiency and oligohydramnios and polyhydramnios. Then documentation of the girth of the abdomen in the last trimester of pregnancy should form a routine part of abdominal examination, helps in diagnosis of the placental insufficiency. Now comes the special investigations. So 30% of the antepartum fetal death are due to the asphyxia. And what are the reasons of the asphyxia? They are IUGR or post-dated pregnancy or during the labor. 30% due to the maternal complications like PIH, placental abruption, diabetes mellitus. Then 15% due to congenital malformations and chromosomal abnormalities. And 5% due to the infection. 50% of the first trimester spontaneous abortions, and 5% of stillborn births, infants, have chromosomal abnormalities. Now comes the chromosomal abnormalities. So they can be the numerical, that is the 47 XXX, or structural, that is the translocations. Single gene, that is the cystic fibrosis, polygenic and multifactorial entities, and teratogenic disorders, that is the drugs. Early pregnancy. Antenatal assessment of fetal well-being in early pregnancy is primarily designed to detect the fetal congenital abnormalities. They are the biochemical, biophysical, and cytogenetic. Now comes the antepartum fetal surveillance, late pregnancy. Prevention of the fetal death. They are the targets and avoidance of the unnecessarily interventions. What are the methods? Clinical methods, biochemical methods, and biophysical methods. So they are the main modes in the late pregnancy to avoid the fetal death. So clinical, they can be useful as a screening for further investigations. They give us a clue. Biochemical, mainly done for assessment of the pulmonary maturity, and biophysical, screening test for uteroplacental insufficiency. Hypoxia, metabolic acidosis, CNS depression, changes in fetal biophysical activity. First is fetal movement count. Second is ultrasonography. Third is cardiotopography, non-stress test, fetal biophysical profile, Doppler ultrasound, vibroacoustic stimulation test, contraction test, amniotic fluid volume. Fetal movement count. Any two method can be applied. Cardiac count 10 formula. That is a daily fetal movement count. We explain the patient to count the fetal movements after the breakfast, after lunch, and after dinner, so that if they are total in 10, it is indicating that fetus is normal. The count should be performed starting from 28 weeks of the pregnancy, because before that, fetus is having movements which are not appreciated by the mother properly. Non-stress test, the continuous, this is non-stress. That means there is no contractions, continuous electronic monitoring of the fetal heart rate along with the recording of the fetal movement. So with the fetal movement, the cardiac heart rate increases. Reactive, reassuring. That is the, what is a reactive NST? When two or more accelerations of more than 15 beats per minute above the baseline and longer than 15 seconds in duration are present in 20 minutes observation. So for simplification, we can remember 15, 15, and 15. So non-reactive, that is the non-reassuring. Non-reassuring means we are having some signs of danger, that fetus is in distress. So absence of any fetal reactivity. Then testing should be started at 30 weeks, as I have told you that because the fetal movements are very good appreciated at 30 or 28 weeks. So they should be started at 30 weeks and frequency should be twice weekly. Then comes the vibroacoustic stimulation. In this, this is also called VAS, changes fetal sleep rate from quiet to active REM. Fetal movement count. So what is fetal biophysical profile? Indications are non-reactive NST. When we are thinking that fetus is not in good situation, then we should go for the biophysical profile. And indications are non-reactive NST, high-risk pregnancy, test frequency weekly once weekly after normal NST. So when we are having a normal NST, then we can do it once weekly, BPP, biophysical profile, and twice weekly after an abnormal test. Modified biophysical profile. It consists of the NST, that is a non-stress test, and ultrasound, and determined amniotic fluid index. Modified biophysical profile is considered abnormal when NST is non-reactive and AFI is less than 5. Now comes the fetal movement count and the biophysical profile. So this is very important. Observation for 30 minutes we do, and normal score is 2, abnormal is 0. So what are the parameters in the biophysical profile? So they are the non-stress test, fetal breathing movements, gross body movements, fetal muscle tone, and amniotic fluid. So you can just imagine a baby, and then you can think about these points very easily. Non-stress test, then fetal breathing movements, how the baby is breathing, then gross body movements, how it is moving, then its muscle tone, and lastly is the surrounding. Okay, so non-stress test is reactive pattern and non-reactive, that we will read in next slides. And fetal breathing movements. So if fetal breathing movements more than one episode lasting more than 30 seconds, then it is normal. Gross body movements more than is equal to 3 discrete body or limb movements, then we give it as a score of 2. Then fetal, this is a period of 30 minutes observation, and fetal muscle tone. So fetal muscle tone more than one episode of more than one or even one of the active extension of the limb or trunk with the return of the flexion, opening and closing of the hand considered normal. And score is 2. These every point has a score of 2. Amniotic fluid more than or equal to one pocket measuring 2 centimeter into perpendicular planes. So this is 2. Then BPP scoring, interpretation and management. So now we have scored कि भी कितना उस पेशेंट का स्कोर है, पीपीपी स्कोरिंग, इंटरप्रिटेशन क्या है, उसका मैनेजमेंट क्या है, उससे हमें पता चल रहा है कि फीटल का स्टेटस क्या है. तो जैसे 8 to 10 है सपोज, सो इंटरप्रिटेशन इज नॉर्मल, लेस रिस्क ऑफ फीटल हाइपोक्सिया, asphyxia, and management will be repeat testing at weekly interval, or even we can do it in 15 days. Then comes the 6, score is 6. Then chronic asphyxia we can think of, and management will be if more than 36 weeks deliver kar de, yadi less than this then, and if LS ratio is less than 2, then repeat the test in 4 to 6 hours, and then we manage accordingly. Then if the score is only 4, then chronic asphyxia, and if more than 36 weeks you deliver it, less than 32 weeks then repeat it, and if 0 to 2 then we strongly suspect asphyxia, test for 120 minutes, and persistent score of if less than 2, then deliver regardless of the gestational age. Now comes the fetal cardiotocography, that is the CTG. There should be no deceleration, or there may be early deceleration of very short duration. There should be 2 or more acceleration during the 20 minutes period. Ultrasound, it will detect the IUGR and including the BPD, AC, SC, and femoral length and AFI. And SC and AC ratio, if more than 1 after 34 weeks, that means IUGR is suspected. Amniotic fluid volume at decrease. Amniotic fluid volume may be the result of fetal hypoxia or any renal problems, placental insufficiency. AFI less than 5 associated with the increased risk of perinatal morbidity and mortality. Doppler ultrasound is very important, and in a normal pregnancy, the ST ratio, PI, that is the pulmonary index, and the resistance index increases as the gestational age advances. So, but higher values greater than 2 ST above the gestational age means indicating there is reduced diastolic flow and increased placental resistance. So these are in favor of the worse outcome and IUGR. Then contraction stress test to observe the response of fetus at risk of for uteroplacental insufficiency in relation to the uterine contraction. We do that. Then comes the antenatal Doppler ultrasound changes and suggestive features of compromised fetus. Umbilical artery, the change will be the reduced or absent reverse and diastolic flow, pathophysiological basis, failure of villus trophoblast invasion, clinical significance, increased resistance in fetoplacental circulation, IUGR preeclampsia. Then MC is important, ductus venosus is important, and umbilical vein is important. So what changes occur in the middle cerebral artery? There will be decreased diastolic velocity and decreased SD or pulsatory index. Dilation, what happens in this? Dilation of the cerebral vessels as a compromise. And clinical significance is brain sparing effect in response to hypoxemia. Okay. Then ductus venosus, increased Doppler index and the absent or reverse flow. And increased CVP will be there, and fetal acidemia will be seen. Umbilical vein changes, increased Doppler index, then increased CVP or decreased cardiac compliance, and the fetal acidemia will be present. In other investigations in the late pregnancy, amniocentesis can be done. That will detect mainly the congenital malformations, then test for fetal pulmonary maturity, for delivery of the baby when we are in dilemma, assessment of severity of RH isoimmunization, that how much the baby will be affected, the antibody level will show us, and pulmonary maturity, that is a confirmation of the lung maturation, reduces the incidence of respiratory distress syndrome in the newborn. Then comes the assessment of fetal pulmonary maturity. Amniocentesis should be done under ultrasound guidance. Estimation of pulmonary surfactant by lecithin sphingomyelin LS ratio. The amniotic fluid LS ratio at 32 weeks is 1, at 35 weeks is 2, and more than 2 indicates the pulmonary maturity. So LS ratio, you can just remember, if it is more than 2, that means it is mature baby. Shape test or bubble test, so that is also called the Clement test. Increasing dilution of amniotic fluid mixed with 96% ethanol, shaken for 15 seconds, observed for 15 minutes for the presence of complete ring or of bubbles at meniscus. And the foam stability test, serial dilution of amniotic fluid to quantitate the amount of surfactant present. FSI more than 47 excludes the risk of RDS, that is the respiratory distress syndrome. And the presence of phosphatidyl glycerol in amniotic fluid reliably indicates lung maturation done by thin layer chromatography. Saturated phosphatidyl choline more than 500 nanogram per ml indicates pulmonary maturity. So there are the other indicators, but most important is LS ratio and easy to detect. Then comes the fluorescence polarization and amniotic fluid optical density, laminar body, then orange colored cells, amniotic fluid turbidity. So these all are other things to detect the lung maturity of the baby. Now comes the assessment of severity of RH in isoimmunization. This is very important in the patients where the mother has a negative blood group and the husband has the or father has the plus positive blood group. This is detected by the amniocentesis for estimation of bilirubin in the amniotic fluid by the spectrophotometric analysis to assess the condition of the baby. The optical density difference of at 450 nanometer give the prediction of severity of the fetal hemolysis. Summary of the antenatal assessment of the fetal well-being. This is fetal surveillance in early pregnancy. This includes the cytogenetic study by the amniocentesis, then prenatal screening, biophysical, by the sonography, congenital malformations, if absent or present, then biochemical. If congenital malformations are present, we can go for the termination of the pregnancy at the right age by explaining all the things to the attendants and patient and the mother and the father. Then clinical monitoring is very important, plus daily fetal movement count after 28 weeks of the pregnancy. Then if there is something abnormal, we can give the option for the pregnancy termination. If daily fetal movement count is normal, then we can continue the regular follow-ups, checkups in the pregnancy and in the term. Then if it is abnormal, and then we go for the NST, and further management will depend on the report of the NST and BPP. Then comes a reactive and non-reactive CTG. So if it is reactive, that means it is good. If it is non-reactive, then if biophysical profile it shows the NST is non-reactive, then we can go for the modified BPP. If it is normal, repeat test at weekly. If it is abnormal, then detailed BPP and droplet velocity study we should do. Thank you so much for your patience listening.